सर गुड इवनिंग।
हाँ धर्मेंद्र जी, क्या हाल चाल?
बस फाइन सर, बिल्कुल। आप कैसे हैं?
बढ़िया एकदम। और बताओ।
बस फाइन सर, बिल्कुल जो है। अंशुल सर, शैल वी स्टार्ट? Yes sir, good evening Anshul sir.
Hey, good evening.
Yeah sir.
I think my voice is clear.
Yeah, voice is clear sir. Shall we start sir the introductory part? After that we will proceed
Sure. I think
yes,
not keep everybody waiting.
Yeah sir, 8:30 ko I think.
Please go ahead.
Yeah sir. Yeah, I think 1 or 2 doctors is pending, but the rest of the panelists are joined sir.
Hello.
Yes sir. Sir, good evening Ramkesh sir. Good evening Kunal sir. Yeah, good evening.
Hello.
Doctors. On the behalf of Supla Vitalists, I would like to welcome all the respected panelists to this ad-board meeting on the role of MR in the heart failures. And today we have with this distinguished speaker, Dr. Anshul Kumar Gupta sir, and he is the senior cardiologist and he will moderate the session. And Dr. Anshul Gupta sir is an interventional cardiologist at Sony Manipal Hospital, Jaipur, doing practice since a long time. And also I would like to request to all the panelists keep your video on for the further better interaction and fruitful discussion on the role of MRA in the heart failures. And today we have with us the panelist, Dr. Ramkesh Singh Parmar sir, he is the MD Medicine at SMS Medical College. Dr. S.S. Daria sir, MD Medicine at SMS Medical College, Jaipur. Dr. Anju Mandil sir, he is working at the SBI Bank, Jaipur. Dr. Kunal Sari sir, Kunal Tuli sir, he is also working in the SBI branch, Jaipur. Dr. Jitendra Sharma sir, he is working in the Government Hospital, Shahpura. Dr. G.K. Jangir sir, he is working in the Vishwakarma Hospital, Mukundgarh. And Dr. Vejan sir, he is the working in GVH American Hospital, Udaipur. And Dr. Harish Sharma sir, he is the MD Medicines, Government Hospital, Bharatpur. Now over to you, sir. अंशुल सर, शायद आपका वीडियो हेलो हेलो सर, मे बी आई थिंक सर टेक्निकल इशू.
हेलो
अंशुल सर शायद वापस लॉग आउट हो गया, क्या हुआ है टेक्निक?
सर अंशुल सर शायद डिस्कनेक्ट हो गए, मैं कॉल करता हूँ एक बार.
हाँ शायद.
अंशुल सर वो नेटवर्क इश्यू हो गया, डिस्कनेक्ट हो गए, वापस लॉग इन हो रहे हैं.
यस ठीक है, ओके.
Hello.
Sir, good evening. Sir, good evening, sir.
Good evening.
Yes, sir.
Welcome all of you. How are you, Dr. Daria साहब?
क्या हाल है भाई?
ये बस और बताओ.
बस सब बढ़िया यार, तू बता.
बस ठीक, मजा आ गया यार आपको देख के.
और बता.
बस ठीक है, मैं तो अभी रगड़ रहा था पर जो बंद कर दिया मैं.
अच्छा है यार. Keep busy, that is the only everybody needs. हर आदमी बिजी होना चाहता है, वो होना भी चाहिए.
Yes, sir.
Being a clinician, we must be busy.
दरिया बहुत मजा आया था मुझे.
अरे
आपको वेट ज्यादा लगता है, बट एनर्जी में कमी नहीं है आपके में, नहीं क्या?
सही है भाई, सही है.
हाँ स्पीकर कहाँ है हमारे डॉक्टर अंशुल गुप्ता?
सर वो एक्चुअली ड्यू टू नेटवर्क इशू डिस्कनेक्ट दोबारा लॉगिन करें सर वो जो है।
अच्छा अच्छा ठीक है।
हाँ सर अंशुल सर रीजॉइन कर रहे हैं, वो नेटवर्क प्रॉब्लम की वजह से डिस्कनेक्ट हो गया था उनका। गुड इवनिंग सर।
गुड इवनिंग गुड इवनिंग।
घर पहुंच
सर
जाएगा
बाकी सर स्मॉल इंट्रोडक्शन डॉक्टर अभय जैन सर is doing practice at Udaipur GVH American Hospital since a long time.
Hello.
Yes. Hello. सर अभी कोरोना का वापिस कुछ लग रहा है डाउट सर अभी जो है, क्योंकि लास्ट वीक में नंबर ऑफ केसेस, लास्ट 15 डेज में नंबर ऑफ केसेस जयपुर में काफी इंक्रीज हुए थे।
पेशेंट्स तो आ ही रहे हैं, कोविड पेशेंट्स आर कमिंग एंड आई थिंक सम आर प्रेजेंटिंग विद finding also.
Yes sir.
Because my radiological friends today I was discussing the things, then he is saying to me that there's patients are coming and even radiological finding are there.
तो इस बार सिम्टम्स सर एज कम टू अर्लियर कुछ देयर इज समथिंग डिफरेंस या सेम सिम्टम्स बलिव आर फाइंडिंग इन द कोरोना पेशेंट्स?
उनके साथ साथ one more common symptom what I am thinking or I am seeing in patients is loose motion.
आई थिंक लूज मोशन का काफी कॉमन निकल गया, लूज मोशन वाला जो है इस बार
This high temperature or other thing also, but some patients have complaint of cough, throat, fever with loose pain or loose motion also.
yes sir. गुड इवनिंग जितेन सर।
गुड इवनिंग सर।
गुड इवनिंग जहांगीर सर। सर ज्वाइन हो गए सर आगे। Yeah, Anshul sir. I think because of network issue, you may disconnected, and all the panelists there, so we can proceed, sir.
Sorry, I kept you all waiting. Just logged out. I don't know, maybe because of the network error or something.
Yes, sir.
I think shall we start now?
Yes, sir. Yes, sir.
One second, I'll just share the slides. I think you have to give me sharing rights. I'm unable to share my screen.
So you are not able to share the slides?
Yeah.
Just
Host has
anybody from anybody with Radiance?
मैं बोल रहा हूँ सरदा मैडम।
मैडम एक बार सर को पोस्ट बना दीजिए।
Yeah.
Yes, sir.
Are the slides visible now?
Yeah, sir. Yes, sir.
So let's start now. A very warm welcome to all the panelists and participants today. And we'll be discussing about mineralocorticoid receptor antagonist, a boon in heart failure management today. See, it's not a very often talked about molecule, but it's very important in the management of heart failure. It's not often discussed well. So we'll be discussing some very important points here today about the mineralocorticoid receptor antagonist. So disclaimer is like the content is of course given by the company people, and it has to be used only for the advisory board. Now we'll be discussing the flow for today's talk. Will be like we'll be discussing all the slides with all the panelists. I shall be presenting a few slides and then we'll discuss things in the form of some question answers, and let us just enhance our own knowledge. Each and everyone can participate. They can unmute themselves and they can just share their knowledge, their experience with all the other panelists, so that we can have a uniform, I'll say a very, very good discussion about this particular molecule today. So our objectives will be to gain insights on mineralocorticoid receptor antagonist placement and utilization in heart failure management. We shall be discussing about this important consideration of mineralocorticoid receptor antagonist, that is hyperkalemia, and we'll see is it really a concern for our clinical practice, and to create the awareness among physicians on mineralocorticoid receptor antagonist. So as we all know, heart failure, it's not a very uncommon thing. It's a very, very common thing, and we all know that the incidence and the prevalence is increasing day by day. There was a time when LV dysfunction, severe LV dysfunction patients were unable to survive for a longer time, and they used to succumb to multiple episodes of recurrence of heart failure, or they would die of some arrhythmias. But now that we have very good medical management interventions, a lot of patients of coronary artery disease will be having severe LV dysfunction, but then they will keep on surviving. They will have a better survival, better quality of life because of the availability of a lot of good drugs available. We all know that the prevalence of heart failure is quite high. It is like 26 million people worldwide are having heart failure. Approximately 1 to 2% of the adult population with heart failure is in developed countries. So we can see just 1 to 2% of the adult population is in developed countries. The remaining burden comes to the developing countries and underdeveloped world. Prevalence increases with age, rising to more than 10% among people of more than 70 years of age. So 1 in every 10th person who is more than 70 years of age is having heart failure. So it becomes a very, very important thing to discuss about. Now, 8 to 10 million people in India are suffering from heart failure. 1% of total population, or about 8 to 10 million individuals. Annual incidence is about 0.5 to 1.8 million new cases per year. And mortality is as high as 0.1 to 0.16 million individuals per year. So it's quite a big number. So we shall be discussing these questions, and I request all the panelists to just unmute themselves and share their views and experience about these questions among all of us. What percentage of heart failure patients approach you in NYHA stage 2, 3, and 4? And how many heart failure patients remain undiagnosed in India at an early stage, and what are the possible reasons for that? So I request all the panelists to come forward and just say something in reply.
I think a significant proportion is most of the patient of the heart failure come to us in the late stage, like stage 3 or 4, because generally they are undiagnosed in India in early stage because they are not aware of the symptoms. It is a lack of awareness, basically symptoms. So generally after some time when they are having symptoms troubling them, then generally they come to us with symptoms of heart failure like NYHA 2, 3 or 4, because they are not very aware of these symptoms of the heart failure.
Very correct. Any other people, their experience?
Yeah, you are absolutely right, Dr. Abhay. What happens in India, basically people are waiting to be reach in NYHA 3 or 4. Once they are in NYHA 1 or 2, they think of that it will resolve very soon. But when he or she land up in stage 3 or 4, then they reach to the doctors. So this is a big issue. And I think we all are in practice. We can see that there are around 10 to 15% of NYHA grade 3 or 4. The cause may be a different, whether it's a volume overload, whether it's anemia, whether it's a heart failure. The cause may be a different, but the dyspnea NYHA class, we encountering at least 10 to 15% patients regularly.
Very true, sir. A lot of patients will come to us in late stage, as has been pointed out by our expert panelist. A lot of patients remain undiagnosed, I would say, because they will be diagnosed sometimes as simple bronchial asthma or COPD, which will be obscuring. The patient might be having LV dysfunction, he is in florid heart failure, but then the symptoms are often ascribed to the just pulmonary system. They won't focus much until they are very late into the disease and they start developing edema and other florid manifestations of heart failure. Only then the concerned physician or doctors will be looking into the heart. Most of the time, these patients, especially the renal failure patients and COPD patients, these are the two important group of patients. Those patients will be usually undiagnosed. They will remain in the, I'd say, with the diagnosis of COPD, I've seen so many patients will be continuing their COPD medications. A lot of inhalational steroids, oral steroids, or beta agonists will be continued for a long time. And then when the patient goes into later stages, say stage 3 or even up to stage 4, and then the patient gets diagnosed. That is a very common scenario in our day-to-day practice. So what are the diagnostic and prognostic tools used by you for your heart failure patients? I request all the panelists to kindly participate. I mean, it will be wonderful if you can share your own knowledge and experience here.
For purpose of diagnosis.
For the purpose of diagnosis.
If we are coming or your patient with complaining of shortness of breath, PND or orthopnea, then we can evaluate the patient regarding the heart failure or other simulating condition as you described in the previous, like just bronchial asthma. It may be the cardiac asthma. For that purpose, we can go for the spirometry and chest X-ray to rule out the respiratory diseases. And for the heart function, we can go for the 2D echogram. And if cardiogram show the any regional wall motion abnormality or ejection fraction of the heart, these things can differentiate between two things. Number one. And for the prognostic tool, we can use some clinical parameters or diagnostic criteria for the heart failure, like Framingham heart criteria for the certain symptomatology, like fetal edema, dyspnea on the exception with NYHA grading, and other things, bilateral facial crepes. On the echo, we can by the left ventricular ejection fraction, and for differential feature pulmonary artery pressure. For the prognostic purposes, there is an BNP level, pro-BNP level, and cardiac markers we can use.
Very right. We can have a battery of investigations to diagnose as well as to have a prognostic insight into the patient. As has been very well rightly pointed out by Dr. Amkesh, we can see a lot of our patients, at least in ECG and echo, those are the basic things which can be done and can reflect upon the patient's LV function at least. Then, as he pointed out, a chest X-ray definitely helps us. Then, role of BNP. Of late, BNP, NT-proBNP is a very important investigation, which is used both for a diagnostic as well as a prognostic tool. Whenever we have a suspicion that the patient is having pulmonary cause or a cardiac cause, use of BNP, NT-proBNP helps us to just differentiate the dyspnea caused by a cardiac cause or a non-cardiac cause. It may be renal, it may be pulmonary, whatever. The differentiation can be made very easily if you just can order a BNP levels. So the cutoffs have been changing for NT-proBNP levels. Of late, the NYHA, the ESC, the European Society of Cardiology, has come up with the cutoff of 125. That is quite low. Previously, it used to be up to 300 for the diagnosis of heart failure. Now they have come up as 125 in ambulatory patients. Those patients who are not in florid NYHA 3 or 4, if they are in stage 1 or 2 NYHA class, we can use the NT-proBNP also. It can be used as a simple marker of diagnosis as well as prognosis. Then, of course, the underlying cause and other things have to be evaluated, and accordingly, the patient has to be treated. Now, this is 2021 update of 2017 ACC Expert Consensus Decision Pathway for optimization of heart failure treatment. It says that a caution should be exercised when mineralocorticoid receptor antagonists are used in patients who have serum potassium concentration more than 5, or severe renal impairment, that is eGFR less than 30, or a creatinine level more than 2.5 in men, or 2 milligram per deciliter in women. So there is a caution about the MRAs, whether it is spironolactone or eplerenone, that if the potassium levels are rising, especially more than 5, or there is a severe renal impairment and the patient is having eGFR less than 30 or a rising creatinine, then a caution should be exercised. Though it does not say that there is a clear-cut contraindication, but then a caution is very much required. So are these parameters, potassium level, creatinine and eGFR, tested before and after initiating MRAs, and how long should we monitor?
Yeah, very interesting question. And what personally I think regarding this question, and with the clinically patients of heart failure, if we are managing, no doubt the mineralocorticoid receptor antagonists have a very good role for the patients of heart failure in the various mechanism, because they have a role in the remodeling of the heart and by decreasing the afterload and preload also. But things, if patient have only heart failure and there is no chance of CKD or acute kidney injury is there. For example, patient didn't have CKD and patient who has history of CKD or renal dysfunction is there, then we can, I think personally, we can start directly. There is no need of measuring the potassium level or creatinine also. But if there is chances of patient have history of CKD or acute kidney injury, or clinically we are suspecting that patient might have a renal dysfunction also, then no doubt before starting the MRAs, we should know about the things of potassium level, creatinine and GFR also. And by calculating GFR, for example, if GFR is normal, then patient have heart failure, then there is no need of potassium testing and even creatinine also. But patient have low GFR, renal dysfunction is there, then before starting the mineralocorticoid receptor antagonist, in my opinion, we should go for the testing of potassium level, because there is a hyperkalemia is there due to the pathology, and starting the MRI, there is chances of increased potassium also. Then or heart failure is there, then these things can precipitate heart failure also. So what I think regarding this question, if patient have history of kidney injury, there is an heart failure or patients, then we can go for starting the mineralocorticoid receptors after checking the potassium and creatinine or GFR is low.
Very right, Dr. Ankesh. Very much, I totally agree, and very important points you have highlighted. If the patient is having renal compromise, that might be a CKD patient, or he is having an acute kidney injury secondary to the renal, the decompensation of heart failure episode. The patient comes and gets admitted with a heart failure episode. He can have an acute decompensation in his CKD, causing acute on chronic kidney disease. Very important factor. If the patient is like an OPD patient, he's not in florid heart failure, no history of CKD, maybe we can straightforward start MRAs, no problem with that. But then if the patient is having a background of CKD or an acute injury to the kidneys, very, very important to monitor both the creatinine levels as well as the potassium levels. Very important thing practically seeing is these patients will also be on ACE inhibitors, ARBs or ERNI. So those are the drugs which can also cause rise in potassium levels. So it is very, very important to consider this fact that the patient, if he is on ACE inhibitor, ARBs or ERNI, when we are starting MRAs, it should be, it becomes very, very important to monitor the potassium levels in those patients. Somebody else's opinion on this regard? How long do we need to monitor potassium in such patients? Insight from some of the panelists. So what we usually do is,
I think the baseline potassium and renal function should be done in almost all patients, I think, because there may be some underlying disease which even patient is not aware, or
Very
So
good.
it is better to go for for potassium and this test, created renal function test, so that we can monitor any serial changes. If it is baseline potassium is 3.5, next time it comes to 4.5, it gives an idea.
Very right. So at least a baseline should be done in most of the patient, if not all.
Not all,
Right.
because
So
if GFR is normal, then what I think personally there is no need. If GFR is normal, that reflects that kidney function is going to be normal. For that purpose, we can start directly also.
yeah, we can, but in case if the patient has come with an acute decompensation, there can be a component of acute kidney injury. That's what I wanted to highlight. Sometimes what the patient may present with a more or less normal creatinine, but the patient is in volume overload. Once that volume is diurized, once the patient becomes euvolumic, his true creatinine levels are reflected actually. Say on admission, if it is like the creatinine is 0.9 or 1, it does not mean that the patient is having a normal kidney function. After diuresis, we may find that the creatinine has risen to say 1.4 or 1.6, 1.8 levels. That is also possible. So it becomes very important to have at least a baseline if the patient is having acute decompensation. That is like my point of view. If the patient is not very decompensated, the patient is well compensated of heart failure, and he is known to have a normal eGFR, then it is not required to monitor every now and then. We can safely start MRIs in those patients.
Okay.
So going forward, heart failure guidelines recommendation for MRI. This is
one query, please. One query. How long it should be? We can given it.
How long?
For MRIs, how long we can use it?
And when you mean
we stop?
Potassium level? When to stop? Yeah, that's what.
How long we can heart failure patients? Question is number one. How long we can use MRI for heart failure patients? Number one. And when we should stop the MRI if we have started previously? What our guidelines say? In your opinion also?
We'll come to some of the guidelines. I'll come to this question. Maybe we can discuss it in the end. There are a few more slides which will discuss this thing also further.
Okay.
But Rakesh will come to that.
Yeah.
So this is ESC 2021 guidelines. Heart failure with reduced ejection fraction. MRI is recommended to reduce the risk of heart failure, hospitalization, and death. This is class 1 indication. And about the heart failure with mid-range, this is a new category actually. Previously, we used to have reduced ejection fraction and a preserved ejection fraction. Now something has come up as mid-range also. This is slightly preserved ejection fraction. MRIs may be considered to reduce the risk of heart failure, hospitalization, and death. That is class 2B indication. So if the patient has reduced ejection fraction, there is a very clear-cut class 1 indication to start MRIs. If it is in the mid-range, then it is class 2B indication. Now, this is a flowchart algorithm for management of heart failure patient with reduced ejection fraction. To reduce the mortality for all patients, there are these 4 important group of drugs which have been found to decrease the mortality of heart failure patients. One is, of course, ACE, ARBs, and ERNI group of drugs. Second is beta blockers. Third is MRAs, and fourth is SGLT2 inhibitors. So these are actually the 4 very important class of drugs which are shown to have mortality benefits. And now it is recommended to start all these 4 drugs as early as possible in most of our patients with heart failure with reduced ejection fraction if the patient is tolerating well. So to reduce the heart failure rehospitalization mortality for selected patient, if the patient is having volume overload, diuretics have to be started. Other things are like if the patient has LBBB with a more than 150 milliseconds of QRS, device therapy may be considered in the form of a CRT-P or CRT-D. If the LBBB has a QRS duration of 130 to 150, then CRT-P or D may be considered. Then if the ischemic etiology is there and the patient is having severe LV dysfunction, ICD may be considered. Other important factors are presence of atrial fibrillation. The patient has an AF further reduces the ejection fraction of the patient. If a patient is having 25% of ejection fraction and is in sinus rhythm, he will be faring much better than somebody who is having an ejection fraction of 25% along with atrial fibrillation. So because with the onset of atrial fibrillation, the atrial kick is gone. So those patients who are having LV dysfunction and on top of that atrial fibrillation develops, the patient is more likely to go into recurrent decompensations because of the AF, usually with fast ventricular rates. So presence of aortic stenosis, if there is an AS present in the patient, then it requires address in the form of a surgical AVR or a transcatheter TAVI. If there is MR, then repair may be required. Heart rate, if it is more than 70 with best tolerated dose of beta blockers, ivabradine is indicated. If the patient is black race, then hydralazine isosorbide dinitrate combination may be considered. Then ACE-ARB intolerance, ACE or ERNI intolerance, ARBs may be tried in that patient. Now, for selected patient who have a very advanced heart failure and they are not managed by all the above intervention, heart transplantation may be a consideration in those patients. Now, to reduce heart failure hospitalization and improve the quality of life for all patients, we should encourage exercise rehabilitation and multi-professional disease management. So now, when do you consider starting MRIs in patients with heart failure along with ACE inhibitor, ARB and beta blockers? So this is an important consideration, see, because as I just now said, ACE ARBs are going to cause hyperkalemia, beta blockers can cause hypotension, and the patient might be having just a borderline hemodynamics. So when do you consider starting MRIs in such patients of heart failure?
For the heart failure patients, it may be acute or chronic with the left ventricular ejection fraction low or preserved. For ACE inhibitor and ARB, no doubt they have a role in the remodeling and decreasing pathology also. So I think they should start at whenever diagnosed as early as possible. Regarding the beta blocker, what I think personally, there is a contraindication if there is an acute heart failure. Otherwise, beta blocker can also use for the heart failure patients.
Very right. So, Dr. Ramkesh, when do you start MRAs? I mean, once the patient has come with, say, a decompensated heart failure, how about your opinion regarding like when do you start ACE inhibitor, beta blocker, and MRA? So, do you try to initiate all three together, or it is like one, then another, then the third molecule?
If there is we can start together all three, because there is for fluid overload and remodeling, rate controlling, and oxidative stress. I think multi-modality approach should be there. So in my opinion, all three should be started simultaneously.
Very right. In fact, there is a guideline from the American Society of Cardiology, that is American College of Cardiology also, ACC guidelines. In 2021, what they have recommended is that we should cut short the duration of time required to introduce all these four molecules. Number one is beta blocker, ACE inhibitors, SGLT2 inhibitors, and MRA. These are the four group of agents which have shown to have very good mortality benefit and hospitalization reduction. So these four molecules, they can be introduced simultaneously or sequentially. There is no problem with that, according to the patient's baseline hemodynamics. But the thing is to start all four as early as possible and then try to up-titrate them as early as possible to the dose which has been shown to have good mortality benefit in all these trials. So, as you have pointed out, all three can be started together also if the patient's hemodynamics permit. But if the hemodynamics are like borderline, maybe we can start one and then add on other, and the third can be. Somebody else's opinion on that?
You said like that hemodynamics should be okay, no? It means like somebody is coming with the heart failure and he or she is already on the ACRB or beta blocker, but BP is around 100 or 110, then you will add or not?
See, for beta blocker, one particular thing to consider is that the patient, if he is in acute decompensation, volume overload state, he should be brought to a euvolumic state. The first thing to do is to start with diuretics and make the patient euvolumic. See, because giving beta blockers in a decompensated patient can further decrease the contractility and can cause further decompensation of heart failure. What should be done in patients who have come with acute decompensation is to make them euvolumic first, giving all the diuretics, whether it is IV or an oral thing. Then we can just introduce beta blocker when the patient has become euvolumic. Regarding ACE inhibitor, ARB, ARNI, previously ARNI were not started directly. ACE inhibitor were started and then up titrated once the patient hemodynamics were stabilized, then ARNI used to be introduced. Now there is a direct to ARNI approach also. This concept says that we need not start ACE inhibitor or ARB in any decompensated patient, but once the patient has become euvolumic, we can introduce ARNI directly now in a very low dose. Regarding mineralocorticoid receptor antagonist, they can be used. One thing is when we are giving high dose of high ceiling diuretics, they can be used as a potassium sparing agent also. Whenever we are going to give a very high dose of loop diuretic, they can cause hypokalemia, and MRAs can very well be used in those patients as a potassium sparing diuretic. So that is one use of MRAs. Then other uses, like if it is not used for that purpose, at least for the mortality benefit, it should be started. Now coming to sir's question, that if the patient is having 100 millimeters mercury of a blood pressure, if the volume is good, the urine output is good, if the patient's perfusion is well maintained, 100 millimeters of mercury is a good enough pressure to start MRAs. There is no problem with that. But if the patient is not tolerating, at least we should initiate in a low dose. We can start with a 12.5 or 25 milligram of spironolactone or an eplerenone, and then we can up titrate to 50 milligram. There is no problem with that. But 100 millimeters of mercury, patient already on ACE inhibitor and beta blockers, we can definitely start. There is no problem with initiating MRAs.
One query from my side.
Yes.
What do you think, and what is your opinion and opinion from other experts also regarding the SGLT2 inhibitors? Because in the heart failure patients, up to till time, I am not using this drug. So what your opinion and other expert opinion regarding the SGLT2 inhibitors other than diabetes?
Somebody want to answer?
Yeah, Dr. Ramkes, we can use that in case of a heart failure due to your diabetes. Even people are using in CKD also as a without diabetes. So the trial says that we can use this DAPA this dapagliflozin only, SGLT2, in the heart failure. But what I think, my experience regarding this MRA, that I used MRA in only the resistant hypertension patients. The patients who were on 3 or 4 antihypertensive, and then you have to give one spironolactone 50 mg, then absolutely the blood pressure come down. So that's why I asked you that question, that if already a patient is having heart failure, blood pressure, definitely the BP will be only 110. In that case, you have to use that diuretic, the torsemide. If we'll use along with that torsemide this spironolactone, so I think I don't have much experience regarding that.
Actually, Dr. Daria sir, I will explain. In patient of hypertension, for example, patient of hypertension, you are saying that resistant hypertension, and we are using the typical classical 3 drugs, and patient is not responding to these 3 drugs, then known as resistant hypertension. After we start the spironolactone, or if you are saying, but after starting the spironolactone, there is a free fluid overload, which is decreased. Due to this reason, blood pressure is controlled in these type of patients. So if
No,
patient,
it's not every time. It's not every time, Ramkesh.
yes, sir.
Like I just seen today morning in OPD, one patient was around 23-24-year-old lady, just newly married, and her blood pressure was around 190 by 110, and somebody has given 3-4 drugs combination. So that is not the condition like that he is having a fluid overload or something else in the 23-year-old. So I just started that.
What I think fluid overload means, there is an covering the all mechanism of hypertension management, because by using the spironolactone, we decrease the afterload. So this might be the mechanism for decreasing the blood pressure, but particularly spironolactone did not decrease the BP so much. So if patient of heart failure, he or she have BP around 100 or 110, then I think we can use the MRA, sir.
Right. So,
What your opinion, Dr. Saab? Yes. Regarding the Darya was question.
see, very rightly pointed out, if the patient is of resistant hypertension, optimal doses of 3 drugs, BP is not controlled, addition of aldosterone or eplerenone can help, definitely. Mechanism, there are several proposed mechanisms as I'm aware. One thing is like as you said, decrease in the volume status. The volume is brought to the euvolumic. They are not actually hypervolumic. They do not have florid edema or something.
Yeah.
But then it brings volume to a more euvolumic state. That is what has been mentioned. Second thing is like cardiac remodeling part and other things. That comes later, of course. It won't come in immediately on starting MRAs or something. In long terms, MRAs do help through the cardiac remodeling part. So that again is a very important thing.
Yeah.
Consider in a long term.
Sorry for disturbance. I think these are the patient of resistant hypertension with cardiomegaly. If give for the X-ray of these type of patients of resistant
Yes.
who have cardiomegaly, in these type of patients, if we are using the spironolactone, then they got better results. Yes, sir.
So it is something like hypertension heart failure patients who are in a very early stage of hypertension patients, those who are having a lot of cardiomegaly, rather I'll say more of LV hypertrophy. The LV hypertrophy remodeling part will be taken care of more by aldosterone, and that is one mechanism that has been proposed. There are several others also, but these two important things are there which can help us to maintain, which can help us in the control of the blood pressure in such patients. So I think we go forward on this.
Okay.
We come to aldosterone escape in congestive cardiac failure. So the importance of time of initiation of mineralocorticoid receptor antagonist on the risk of mortality in patient with heart failure. Now, use of MRAs as early as possible on top of treatment, that is ACE-ARB or beta blocker, preferably at discharge after an episode of decompensated heart failure. So this point says that we should try to use MRAs as early as possible. That's what we were discussing. These are the foundational therapy, what we call ACE-ARBs, beta blockers, then SGLT2 and MRAs. All 4 of them are foundational therapy. We should try to initiate as early as possible. Whenever a patient is admitted with decompensated heart failure, we should try to initiate as early as possible. Following an acute fall in the aldosterone in response to administration of ACE inhibitors, the level of aldosterone rises again and indeed returns to baseline in almost all patients, which is known as an aldosterone escape mechanism. What happens is whenever we are using a RAS blocker, that is renin-angiotensin-aldosterone system, whenever it is blocked at any level, be it renin inhibitor or ACE inhibitor or an ARB, what we are doing is that the level of aldosterone goes down. But the patient's aldosterone escape mechanism occurs after some time, and then the aldosterone levels start to get back to the normal baseline level after some time. This usually takes a few weeks' time. Even when an ACE inhibitor is given in combination with ARB, aldosterone levels remain uncontrolled. Actually, ACE inhibitor is given in combination with ARB. This is not a very good combination because whatever trials have shown is that either ACE or ARB should be given. Combining both of them have not shown to have any benefit, mortality benefit, rather the risk of hyperkalemia increases. Aldosterone escape might promote release of angiotensin II via positive feedback loop that stimulates the ACE in the vasculature. The progressive escape of aldosterone are thought to contribute to the ACE inhibitor resistance, whereby the effect of ACE inhibitor becomes blunted and the beneficial effects on mortality decrease over time, whereas MRAs are able to antagonize the deleterious effect of aldosterone, resulting in a beneficial effect on the patient mortality. So it's a very important concept of aldosterone escape. When we are giving ACE inhibitors, we are trying to decrease the RAS excess. The aldosterone which is generated through the RAS axis, we are trying to inhibit at the level of ACE or at the level of ARB. But after some time, it can revert back to normal. The levels of aldosterone can go back to normal. If we initiate an ARB, the angiotensin receptor blocker, and then initiate MRA also. So we are blocking at two different levels, and then the RAS axis can be taken care of. Whatever increase in the aldosterone comes, that can be taken care of. Aldosterone receptor blocker. Now, comparison between spironolactone and eplerenone on LV systolic function in patients with chronic heart failure. This was a study published in University Heart Journal in 2020, and we can see that improvement in systolic function was significantly more in eplerenone group. So both spironolactone and eplerenone act more or less in the same way, but an important difference between spironolactone and eplerenone is that the spironolactone can cause a few side effects of like gynecomastia. Eplerenone is devoid of those side effects. What we see here in the chart is that LVIDD, which was at baseline 51.1, was reduced to 48.7. This is actually a marker of LV remodeling. In eplerenone, from 52, it went down to 45% with a very significant p-value in the difference. Similar thing with end systolic volume and the rise in ejection fraction also. LVEF has improved from 34.7 to 38.3 in spironolactone after 6 months. And after 6 months of eplerenone therapy, EF improved from 34.1 to 40.3. So in this trial, it was shown that spironolactone, eplerenone was shown to be slightly better than eplerenone. Now, when do you prefer using spironolactone or eplerenone? Any specific patient profile or not? Is it always that you start with the spironolactone and if the patient develops side effects, you switch to eplerenone, or de novo you try to start up with eplerenone itself? How is the practice among all of you? Dr. Ramkesh, your views?
First of all, I have a little experience regarding the eplerenone because I have just started then using the few patients of heart failure. Number one, what I think personally regarding this drug is that one benefit is of regarding the cost with spironolactone, cost difference with eplerenone. Number one. Other thing is that if we can start with spironolactone, but our patient is developing the gynecomastia, then we can change to the eplerenone. And regarding the next starting point is that study again and again are coming is there. Then no doubt there is an LV remodeling and other benefit are also there. So we can start initially also. But regarding my opinion, I am going with presently also with the spironolactone. And if my patient is developing the gynecomastia and other complaint, or there is an improvement is there, resistance is there, chances of less improvement or less benefit to the patient, then I can change to the Eplerenone. This is my opinion. I started just recently from some study in fresh patients. Number one, I changed to the Eplerenone to the new patients of resistant gynecomastia is there. And if patient didn't get benefited and complaining is similar, then I can change to the Eplerenone. There are three indications in my opinion.
Very rightly pointed out, cost definitely plays a very important role here, because Eplerenone was a bit costlier than compared to the spironolactone. We all have a tendency to start with spironolactone, and if the patient develops side effect, maybe we can switch to Eplerenone. But then if the patient's cost or finances are not a concern, maybe we can just straight away go for Eplerenone also. Second thing is, because the patient is already overburdened with finances because of the usage of multiple drugs, so the choice of MRA initiation or not initiation is important. Choice of agent becomes secondary. So most of us will tend to start with spironolactone first, and the patient develops gynecomastia and other side effects, maybe we can switch on. But of late, if the prices have come down, we can consider to go ahead with the directly Eplerenone also. This question, I think, Dr. Amkesh, you were discussing about the potassium levels, what to do, when to do, how to stop, and how far we can go ahead with increasing or decreasing the dose adjustment part. So this is a chart which shows most of the potassium thing. Regarding spironolactone and Eplerenone, here we can see if the baseline EGFR is more than 50, then spironolactone can be started at 25 millimeters per day, 25 milligrams per day dose. If EGFR is 30 to 50, then 25 milligram every other day. So if there is a compromised renal function of 30 to 50 EGFR, 25 milligram every other day, alternate day, can be used. Then if the potassium is less than 4, we can increase the dose of spironolactone. If spironolactone was 25 milligram per day, we can increase to 50. If spironolactone was 25 alternate day, we can increase it to daily. So that is if the potassium levels are on a lower side, that is less than 4. When it is 4 to 5.5, that is in the normal range, we need to continue with the same dosage. We should not try to up titrate in such patients. Now, if the patient is developing hyperkalemia, that is, the potassium is in the range of 5.5 to 6. Now we have to decrease the dose from 50 to 25, or if it was 25, we can make it alternate day. If the spironolactone was 25 alternate day, then we have to interrupt the treatment, and then we have to reassess potassium within 1 week duration. So this is how 5.5 to 6 potassium is managed. If potassium levels go above 6, we need to stop MRA treatment and reassess potassium levels after 1 week. If the potassium levels come to less than 6, we can initiate a potassium binder and reintroduce MRA also. Then we can stop MRA treatment in any case if EGFR is less than 30, and we can reintroduce upon clinical decision, that is upon renal function improvement and potassium stabilization. This is how we go about spironolactone. Almost similar thing with Eplerenone, but here if EGFR is more than 50, go directly with 50 milligram per day. 30 to 50 EGFR, Eplerenone can be given in 25 milligram per day. If the potassium levels are on a lower side, that is less than 4, Eplerenone 50 milligram per day, we can increase up to 100 milligram per day. If Eplerenone dose is 25 milligram per day, then increase to 50. Again, if it is like normokalemia, just no dose adjustment required, continue. 5.5 to 6 potassium, if Eplerenone dose is 100 milligram per day, decrease to half, 50. 50 hai, then we have to go for 25. If 25, then alternate day, or we can interrupt and reassess potassium within 1 week. If it is more than 6, obviously we need to stop MRAs and reassess within 1 week. and we can reintroduce with a potassium binder sometimes. If it is stop MRA in treatment, in any case, if the EGFR is less than 30. So this is how we go about the potassium management with spironolactone and eplerenone. So now what is the preferred dose in your practice, and how is the dose titration carried out in your practice? This is how the guidelines have been, but how do we all manage in our OPDs? See, because sometimes it is not possible to monitor potassium levels so often. We can't say a patient to go and get his potassium checked every weekly. It becomes very difficult. So how do we do that? How everybody is doing in their own clinical practice? Please, if you can share your views.
I think what I think regarding the prepared dose titration in my practice. First of all, thing is that I start with a low dose, for example, 25 milligram. And after starting the dose, hello.
Yeah, please.
Yeah. After starting the dose of 25 milligram, if my patient didn't have any sign of hypervolemia regarding the edema and other things, and patient did not complaining the cramps, because with diuretics, cramps are very common, then I continue the same drug. If patient symptoms did not improve, or patient having the edema is there, then I increase the dose for the 50 mg. This is the my dose titration pattern or schedule for the clinical practice by seeing the patient volume status, patient symptomatology, and certain complaints regarding the cramps and leg pains. By these things, I manage the dose of spironolactone in patients of CHF or heart failure.
Okay. Somebody else's view on that?
Yes, usually in our clinical practice, start with low dose, as already said, and then again on follow-up, looking at the clinical condition of the patient, is there the improvement in the symptoms as well as level of potassium and sodium because of using the combination of diuretic. So according to the clinical symptoms, clinical condition symptoms and potassium levels, we can decide the increasing the dose of MRA in that kind of patients.
How often have you come across more than 6 of potassium with MRAs, ACE inhibitor combinations, ACE or ARB or ARNI, whatever? Have you come across?
Maybe 10 to 20% patients, potassium is more than 5.5. But generally, it is not very common with low dose of MRA when we are using.
It's not. It's not very common. And,
I think what I think, sir. One thing is there. If patient of heart failure and we are using the loop diuretics with spironolactone, then chances of hyperkalemia is very less. If patient didn't have renal dysfunction, what I think, if patient didn't have renal dysfunction and we are using the loop diuretics with MRA, then chances of hyperkalemia is very less. So personally, I didn't see the hyperkalemia in patients of heart failure without the CKD or renal dysfunction patients, if we are using the loop diuretics with MRAs.
Right. Very correct. Even if the patient develops hyperkalemia, it is not to very alarming levels, unless patient has CKD or acute kidney injury in such patients, as rightly pointed out by our expert panelists. Another thing is, most of the patient will tolerate well the hyperkalemia. They won't have ECG changes or other things. They will remain asymptomatic in most of the cases, and the rise in potassium levels will be to the level of, say, up to 5 or up to 5.5. I have not seen much patients more than 6 potassium if the patient is having the background kidney disease. If background kidney disease is there, then definitely the patient can develop more than 6. But otherwise, if the patient is having normal kidney function, it is very difficult. It is not very common to see alarming levels of potassium. So this is a meta-analysis which has shown that the prevalence of hyperkalemia was 9.3%, out of which 54% was truly related to MRAs. So, as just now pointed out, that up to 10% of the patient can have hyperkalemia. That is what it was seen in this study also. And 54% was truly related to, so only half of the patients were truly related to MRA, other half had other causes of hyperkalemia. So, what percentage of patients on MRA develop hyperkalemia and do they require discontinuation of treatment? So, have you discontinued our MRAs because of hyperkalemia per se, only because of the hyperkalemia? And if yes, in how many percentage of patients? How are these patients managed by you? Any views on that? I think not much of the patient required discontinuation of treatment. Maybe we can just decrease the dose or make it alternate day. That much has been done, but most of the patient can continue to be on MRA unless they develop severe renal insufficiency. If the eGFR goes less than 30, such patients are very prone to develop hyperkalemia, and those patients we don't try to go for MRAs. Otherwise, discontinuation is not that common because of the hyperkalemia thing only. Now, timing of eplerenone initiation and outcome in the patients with heart failure after acute MI complicated by LV dysfunction. This is insight from the classical FSS trial. So, what is seen here is earlier administration of eplerenone, that is within 3 to 7 days, that is within the initial first week itself. It improved the outcome in patients with LV systolic dysfunction and heart failure post acute MI. So, acute MI patient, if they are started on eplerenone within 3 to 7 days, we can see here in these graphs that the survival rates were better when the eplerenone was started earlier. This is a follow-up of almost 2 years. We can see there is a marked divergence of these two graphs. If the eplerenone was started earlier, the survival were better. Then there was a 34% reduction in sudden cardiac death in patient post MI heart failure by eplerenone versus placebo when initiated before 7 days versus after 7 days. So it is within 1 week or after 1 week. Within 1 week versus after 1 week, we can see a survival advantage has been shown that if it is initiated early, then the survival is better. So in clinical practice, how early are MRIs initiated for management of heart failure patient? So, anybody's take on that?
Yeah, you explained in previous slide. I think personally, we should start as early as possible after diagnosis.
Diagnosis of MI?
No. After heart failure diagnosis, we can start.
Yeah. What they have shown is that within 3 to 7 days. So, I think we can definitely start MRAs. The important role of MRAs as potassium sparing agent is also very, very important. See, once patient has come with an acute decompensation, we are giving IV dosage of loop diuretics. Patient is very much prone to develop hypokalemia. And then MRAs can be used in that fashion also. It will have dual benefits of the managing the potassium levels, preventing hypokalemia, and the patient will have a survival advantage also. The mortality benefit what we saw in the previous graph. So it becomes very important. Another very important thing in acute MI patients are that the myocardium is very irritable. So sometimes we tend to maintain the potassium levels above 4. They are very prone to throw up arrhythmias, especially the ventricular arrhythmias can develop from LV because of the acutely infarcted myocardium. We always tend to maintain potassium more than 4. So MRIs can be a very good choice if the patient is having LV dysfunction, heart failure due to acute MI. They can be a very good choice to initiate early. One thing is to maintain potassium levels, optimal level of diuresis, and then third thing can be we can have a survival advantage also. So therapeutic algorithm for class 1 therapy. It is ACE, early beta blocker, MRA, then SGLT2 inhibitors. These are class 1 indication. If the patient has fluid retention, then maybe we can use a loop diuretic also. If LV is less than 35, QRS is narrow, ICD may be required. This is actually we initial 40 days we observe for the infarct to mature. Even then the patient tends to have these things, we can go for a ICD. Then LV ejection fraction more than 35 or device therapy is not indicated or inappropriate. Then if symptom persists, consider therapies in class 2 recommendation. If sinus rhythm is there, LVEF is less than 35, QRS is more than 130, then CRTD may be. At what stage heart failure, diuretic and MRA both are needed. I think if the patient is in volume overload, both diuretic and MRA can be started simultaneously. Torsemide and eplerenone combination or torsemide spironolactone combination, these are very good choice of agent if the patient is in heart failure. What is your preferred choice of therapy among all these four, A, B, C, D? I think everybody should participate.
I think I already discussed the preferred choice of therapy. If we go for eplerenone is a more basically more specific for the MRA in comparison to the spironolactone with less side effects. So it is ideally started eplerenone plus torsemide, and the cost is the issue, or then we can go for spironolactone plus torsemide.
Very right. I think others also have same views. So for all the panel members, this question, in your practice, any other indication apart from heart failure where MRAs are used? I think Daria sir has already answered that question regarding resistant hypertension.
Yeah. One indication is resistant hypertension. Next, CLD patients or cirrhosis patients.
Very good.
Yeah.
Cirrhosis patients.
Indication, I think if patient in volume overload and patient have I think kidney injury is there and output is low, then we can also use this drug for the fluid overload for the patients of kidney, like renal injury patient, AKI or CKD. If because one diuretics, Gitanix, this is an alternative for the Lasix or torsemide group drug, Gitanix. So I think this may be indication for volume overload in renal patient also. But if output is adequate or GFR is good and creatinine is low, then what do you think? So indication other than the heart failure is number one, resistant hypertension. Next is the cirrhosis or CLD patients, and third is patient of renal patients for volume overload. And these type of patients who have resistance regarding the diuretics.
It can be the first two, as you pointed out, are very, very important indications. Cirrhosis patients, a lot of cirrhosis patients will be on MRAs, that too in a very, very high dosage. We as cardiologists are not using very high doses of spironolactone, but then the gastro and physicians, all of you are using very high dosage of.
More thing, sir. Please, I'm disturbing in between. Sorry.
Please.
Gynecomastia is very common with MRAs in the patient of CLD, because in these type of patients we are using the high dose. Gynecomastia with spironolactone is very low in the patient of heart failure.
Very right. Because we are using in a higher dose.
Yeah, low doses.
Yes. Other thing regarding kidney failure patients, sometimes it is difficult to manage the hyperkalemia part. So sometimes
but no doubt in kidney patients there is a risk of hyperkalemia is there. So prevalence be avoided.
See, if the patient is educated enough and he is well informed about hyperkalemia, and if he understands the importance of hyperkalemia, he is ready to monitor the levels. It can be used, MRAs can be used wonderfully. But then if the patient, as most of our patients will be from a rural background, they will not understand the importance of what potassium, why to go for recurrent blood checkups. In such patient, if the patient is not so much cooperative, it becomes very difficult to maintain. So that consideration should be there in most of our patients. If kidney failure is there, I personally tend to avoid using MRAs in those patients who have just say EGFR of less than 30, or even in 30 to 50 also sometimes it is difficult to manage. Wonderful discussion, I'll say. Very much thanks to all the panelists here, especially, those who have actively participated. I expected very much good participation from everybody. And I think we have discussed well this particular molecule, both spironolactone, eplerenone, then the side effects, their indications. A lot of good points have come up, I think, especially from the physician's point of view. We as cardiologists become very much focused on heart failure and all. And more of coronaries and heart failure. A lot of different points have been brought up now. I think this was a very fruitful discussion. Thanks to CIPLA team, everybody here who have participated, and I thank you all to join this session. Maybe we can discuss further.
One or two query and questions starting from my side, doctor.
Please.
First of all, thing that we know that we are using regarding the rhythm. If patient heart failure with the irregular rhythm and diagnosed as a atrial fibrillation. So for the rate controlling drug, which drug is most important? I think digoxin, or should we go for the CCVs and beta blockers or evaporating? One thing I read in my unit is that beta blocker are contraindicated patient of a weak heart. If patient have weak heart, digoxin should be contraindicated. Then we can use the digoxin patient of heart failure with the reduced ejection fraction with atrial fibrillation. Is this right choice?
Yes. I'll say partly yes rather. Digoxin is having a very limited indication now. Digoxin is now used only in those patients who have heart failure plus atrial fibrillation and more or less a normal renal function. There are several important things here. One thing is digoxin is having a very narrow therapeutic window. If you give it in a very low dose, it will go into a subtherapeutic range. If you just try to increase the dose, it can just overshoot and go into the overdose range. So that narrow therapeutic range and these arrhythmias that you will get out of usage of digoxin toxicity are so difficult to manage. See, I've seen many patients nowadays. Those patients are less common to have digoxin toxicity. But then during my MD and DM, we used to see a lot of digoxin because digoxin is the only drug which is given to increase the contractility of heart directly. There is no other drug to use to do that. I mean, the oral drug. Catecholamines can be used. I mean, you can use dobutamine or dopamine and other things, but those are all injectable agents. If you want something which is used as a cardiotonic agent, that is to increase the contractility, there is only one drug which is digoxin. So it was a favorite of most of the cardiologists, physicians previously, but now more or less the indication of digoxin is limited to heart failure patient with atrial fibrillation. This was shown in DIG trial that the rate of recurrent hospitalization was reduced with the usage of digoxin in such patients. Apart from this, I don't prefer using digoxin in any of my patients. See, because a lot of other drugs have come up. There was a time when these cardiac glycosides were being used for this purpose. Now, all the antihypertensive, anti-heart failure therapy, if you see, there is no indication of digoxin. It has totally gone out of vogue now. Another thing, to control rate of atrial fibrillation. Few important considerations. Digoxin, as I discussed, yes, it can be used. It's a narrow therapeutic window. Please use in patients who have a normal renal function or more or less a normal renal function. If the renal function is deteriorating, be careful about the digoxin part. Second agent is regarding beta blockers. Beta blockers should be avoided when the patient is having an acute decompensation. If the patient becomes euvolemic, if you have sufficiently diurized the patient, if the patient has come to normal volumic status, please initiate beta blockers for all heart failure patients. It can be a preserved ejection fraction, reduced ejection fraction, middle range, anything, whatever. All heart failure patients will have a survival advantage, that is a mortality benefit with beta blockers, but it should be chosen, very wisely. You initiate when the patient has become euvolemic and then up titrate to the level that the patient is able to tolerate, or you reach up to the level those that has been shown to have benefit in clinical trials. So we tend to start beta blocker when the patient has become euvolemic, and then we up titrate. It depends on the patient's hemodynamics, how we can up titrate. We can up titrate early also. Every 3 days you can up titrate, or weekly you can up titrate. Depending on the follow-up and other things, you can up titrate to the maximum tolerated dose. Second thing, if the patient continues to have heart rate more than 70 on the best tolerated dose of beta blocker, then there is an indication of ivabradine. Otherwise, ivabradine is not shown to have a survival advantage. It should always be beta blocker if the patient tolerates well. If the patient is not able to tolerate, then we can add on ivabradine on top of a beta blocker. Third important thing is, ivabradine should not be used in patients who have atrial fibrillation. It is only indicated in patients who have sinus tachycardia, which is not controlled with an optimal dose of beta blockers. Another choice of agent is CCBs. CCBs can be used if the patient is having atrial fibrillation, but more or less a preserved ejection fraction. If the patient is having a lot of LV dysfunction, if it is like severe LV dysfunction, less than 30% of ejection fraction, please don't go straight away to a the choice of CCB. CCBs can further decrease the contractility and can decompensate the patients. So in those patients who have preserved ejection fraction, at least ejection fraction should be more than 30%. Patients is having atrial fibrillation, choice of agent can be any CCB. I mean, it can be verapamil or it can be diltiazem. Either of it can be used. There is no problem with that. Final thing remains amiodarone, which is like, it is like a rambar. You can use in any patient, but then the drug is toxic. It, from head to toe, it can cause any organ dysfunction, be it eyes or your liver or your kidneys or whatever. I mean, so many toxicities are there with amiodarone. But if it is used in a rational way for a short term, the toxicities can be avoided, and it can be very well given in patients who have just borderline hemodynamics, severe LV dysfunction, heart failure. Those things are there, and atrial fibrillation, the fast ventricular rate. There we can use amiodarone as the drug of choice. So, Pramkesh, very important question.
Yeah.
This is a very practical question. We often face day in and day out, but a few things I've tried to highlight in just 2 minutes. Most of the things, if you keep remember these part, how very well management of atrial fibrillation can be done.
Thank you very much. Thank you.
I again thank everybody for their active participation.
Yes, sir. Thank you very much to Dr. Anshul sir and all the panelists, Dr. Adke sir, Dr. Rajan sir, Dr. Harish Sharma sir, Dr. Nal sir, and Dr. Anjumani sir, Dr. Jitan sir, Dr. Vikitangir sir. Thanks a lot for your valuable time and efforts.
Thank you very much.
Any other queries, sir, you want to ask to Dr. Anshul sir? Apart from our question answers.
Very nice. And the meeting, very good discussion. I think.
I don't know. Now I'm seeing that the time is 9:50. I'm sorry I extended the meeting. I might have bored you a lot. Thank you, everyone.
Any other topics, sir, you want to suggest in future, so we can plan such type of meetings, like panel discussions?
Yeah, we can. I think this is more fruitful to have a very much close discussion about anything. It can be, I'm a cardiologist, any cardiac thing, whatever, I mean, medical part or intervention part or whatever, a small meeting like this is very much helpful. So
yes,
maybe we all can just gather again some other evening and we all can discuss again on some other topic, maybe something.
Thank you.
Thank you so much, everybody. Have a very
okay, sir. Thank you very much to Anshul sir, all the panelists. Thanks a lot, sir. Good night, sir. Anybody from panelist? Hello. Anybody from Rhythm?
हाँ मैं फोन कर रहा हूँ सर, फोन कर देता हूँ अभी उनको ना.
Hi.
हाँ मैडम,
Yeah, meeting is over.
मीटिंग इज ओवर है ना.
I'll confirm. Okay. Yeah.
Kindly share the link, है ना?
Sure.
Yeah. Thanks a lot.